Thank you very much, Rob. That's one tough act to follow. I can tell you that cannabis is also a plant. I won't be cooking or making any edibles this morning with it. But I do want to thank you, Sylvia, the entire Alberta Pain Society for the opportunity to present to everyone this morning. I'm going to jump into my disclosures. I will be talking about a 2,000 patient study that we've launched across the country at the end of this, and I'm a non-paid consultant of Shoppers Drug Mart as it associates to those slides. And there you see some of the other disclosures as they pertain to what we're going to talk about this morning. Before we jump into the meat of the matter, I wanted to talk a little bit about this paper that's kind of showcasing the collaboration we have between Rob's team and myself in Ontario. And when the COVID pandemic started, we realized that we really needed to share some of the protocols that are available for things like Suboxone or buprenorphine, naloxone switches for patients in particularly struggling with their high dose opioids. And Rob presents a very nice case. We don't always present our cases that are run perfectly like textbook, and we struggled with one, and we were very much able via telehealth and collaborating between the two centers to figure out the path forward for some of these folks. And so if we look at day one and day two, you have a good pathway for some of these patients. And this was published just in September and has been online since the summertime. Okay, so this is a slide that I often end with, but I'm going to start with today. And it really encapsulates what the journey has been for the past 7 years in the cannabis industry since it's been thrust kind of into the physician ballpark. And what I can say is that we all know that there's lots of interest in chronic pain. The vets are using it for PTSD, and Epidiolex south of the border is now an FDA-approved drug. It's a plant-based extract for seizure disorder, in particular with children with Dravet and Lennox-Gastaut syndrome. But, you know, take a look at the rest of that bubble, and I can already tell you that docs were interesting creatures, and we like to start to use medications that we think, or plants that we think might be helpful across the spectrum of multiple disorders. And you show me a chronic complex condition that doesn't have a sleep, anxiety, or a neurodegenerative angle to it that someone may not be interested in the use of cannabis. And so this is one of those areas where the science has to catch up to what we're doing clinically, and this is certainly why this is at the top of the radar at the moment. I want to talk about what the use of cannabis has been over the past years. And, you know, if you ask any Canadian right now, 40% of Canadians will tell you, yeah, of course I've used or consumed or trialed cannabis at some point in my life. 10% of Canadians, that's 37 million, so about 4 million Canadians almost, will tell you, yeah, I use this pretty regularly, and it's either recreational use or to help treat some medical condition. And if you look at 2018 in October, when we officially became the second country in the world to legalize cannabis from a recreational standpoint as well as a medical standpoint, the monthly sales of cannabis was about $41 million a month. In March of this year, when we entered COVID, we had to ensure that our population had alcohol. We also had to ensure that they had their cannabis products. And so that monthly sale is now up over and hovering around $200 million on a monthly basis. And so we started to realize we really better start to think about what the guidelines should look like when these 3.7 million Canadians approach us as a healthcare entity. And so this is a prospective study of about 600 patients that we're presenting to the Toronto Western Hospital with some colleagues of mine that I'll introduce in a few slides. And they were presenting for their hip or knee replacements. And I can tell you that 16% of the population was consuming a cannabis-based product for their arthritis or their MSK pain. And about 22% of them had at least trialed it for their arthritic related pain upon presentation to the clinic. A quick dive into the predictors of those that were using it. You know, the younger you were, that's not a surprise. All of the things that we know from the pain setting is that if you had a history of depression, if you had ongoing back pain, if you had more than 4 painful areas, or you had pain for greater than a year, you had a higher ratio of using cannabis. But the strongest predictor were if you were a recreational cannabis user in the past, that denoted your highest likelihood of continuing to use cannabis for your medical condition. When you look at those that were using cannabis and dug a little deeper, we know we have the story of CBD being the utopia molecule that aids and heals almost anything that is happening in society. Well, only 1/3 of patients were actually using a product that was CBD based. A quarter of the patients had no clue what they were taking, and I think this is something that we're starting to realize as physicians. Unless we start to understand these products a bit more, patients are being left to the discussions they're having with almost anyone with respect to what they can use for their medical ailments. 2/3 of patients are using cannabis daily to manage their pain, and 1/3 of folks were spending about $100 to $150 a month. And a quarter of these patients were advised by a physician. But what's interesting is only 1/3 of this subcohort was actually buying it from a Health Canada licensed provider. And when we think back to that $180 million monthly spend currently, you can imagine what the number actually is as a economy as it relates to cannabis on a monthly basis, given the 2/3 not even consuming it from a legal means. So what we decided to do was to take it upon ourselves to create a Delphi protocol to manage these patients as they present, in particular, to the operating room. And I can tell you there are other publications like this. There are other Delphis that are out there. By 2021, you're going to start to see guidelines as it relates to oil-based products versus plant-based products, et cetera. So this is, fortunately, we were able to have this one accepted a little bit ahead of the others. I would have liked some of the others to have been accepted in the past. So before you proceed to do a Delphi, you actually have to start with at least a good systematic review of the literature. And I can tell you that there was very little when we dug into looking at the perioperative period in human trials. And so we had to expand this beyond humans. And what we did was we looked at the entire literature as it relates to the perioperative environment. And we ended up with about 27 articles. And so, this was published in Cannabis and Cannabinoid Research in 2019. They have a 1-year embargo. So in a couple of months, this will be probably open access. And, we dig into the cardiovascular effects of this plant, the respiratory, the GI, and the hematologic system, as well as touch on some of the pharmacology as it associates with our anesthetic care. So here is the team of folks that were put together to accomplish this Delphi. I will tell you that it was the largest Delphi that I've been associated with. There were 1,800 questionnaires, and these poor individuals went through these questions one by one. You can see Rob's name there. We have a host of Canadian docs. We have anesthesia representation, surgical representation, family medicine, addiction medicine, nurse practitioners, as well as patients. And there is representation from Canada, US, Norway, the UK, Australia, New Zealand, a pretty global panel so that we can have this as relatable to what the local policies are. And clearly, each one of these recommendations are related to and can only be enacted in the jurisdictions in which we practice. So this is by no means the Bible. This is one of the first documents to at least stimulate discussion so that we can start to talk about this as things move forward over the next 5 to 10 years. And so what did we want to really give some guidance or some suggestions to? And the first thing is we really wanted to be relevant to any diagnostic or therapeutic procedure. We wanted to talk about, preoperatively, whether or not we should wean individuals based on specific doses, whether or not nabilone or dibixabols, the actual DIN products we have available to us, can be useful in these patient populations. We had some discussions with respect to adjunct analgesia, regional anesthesia, depth of anesthesia monitoring, as well as post-op nausea and vomiting prophylaxis. And of course, ensuring that you have an outpatient, if you have an outpatient authorizer, that there is a link back to those individuals. The one thing that was important, and this is something that I really think there's a misconception of these plant extracts, are what denotes a CBD versus a THC dominant product. And it was pretty clear through some of the other Delphis I was involved in that unless you had more than 10-to-1 of a CBD-based product, that really is when you can start to consider something CBD dominant. Any of these balanced 1-to-1 products, most of the effects are probably being driven by the THC. And we all know that CBD has some of the negative allosteric kind of modulation effects, or basically dampens down the psychotropic effects from the THC. We touched on the definition of cannabis use disorder. We defined what high-dose cannabis use was and discussed cannabis withdrawal in the perioperative environment. And so here is the first of the figures in press. Everybody likes a nice figure. This is a preoperative kind of management figure. Whether there's a therapeutic or a recreational use, we defined high dose, and you can look throughout the literature as anybody consuming greater than 1.5 grams a day of inhalational cannabis, greater than 300 milligrams a day of CBD-based oil, and greater than 20 milligrams a day of THC-based oil. And I can tell you that there was a discussion about 20 versus 40. Some of the other documents that are coming out by the Brits, et cetera, denote 40 milligrams as that dose whereby which you should start to seek a pain specialist if you are now consuming that much or more and still needing to continue on higher doses of THC-based products. And we got to, how do we as a group, this large group of experts, decide what we do in the preoperative period? And it was pretty clear if someone's presenting to you, as they do quite often in today's healthcare environment, the day before surgery, you're going to do nothing to these folks, and you're going to take care of them as best you can and get them through the perioperative period. If you see them greater than 7 days out or months out for that matter, we can start to have those discussions with individuals that are using this for a medical purpose in terms of how we might be able to facilitate your care. But there was certainly absolutely no consensus in what to do in that middle ground, and certainly something to stimulate further discussion as things move forward. This was the perioperative kind of management plan. Again, keeping in mind those specific cutoffs that I talked about earlier. We all know of those anecdotal stories from our colleagues that are telling us that, I had a real cannabis consumer who I'm in the OR and I'm not sure. They look like those BIS numbers were very high, so depth of anesthesia monitoring was certainly something that was recommended. We touched on post-op nausea and vomiting prophylaxis and the need for potentially more vigilance to help prevent that, and also had a discussion in terms of ensuring that if your patient is going to be an inpatient, then an acute pain service referral is made around the time of either pre-surgical assessment or on the day of surgery, obviously by the attending anesthesiologist. When we look at what's happening in the postoperative period, beyond the immediate post-op period, clearly someone that's in hospital for a while and has been consuming an inhalational product that might be high in THC will not have that ability to be hooked up to their oxygen as well as continue to inhale their products. And so does substitution make sense? And we do suggest that nabilone and nabiximols are potential candidates for substitution during that postoperative time period, and obviously do not recommend the same for CBD-based products should your patients not be able to continue these long-term. And I can tell you, the whole period is to also stimulate those discussions at the hospital level in terms of what we can do to manage patients as they continue to move forward and continue to use these products. The use in Canada and the trend in Canada is continuing in the upward direction. So here are some of those colleagues I was mentioning. Dr. Kapoor is now the head of a brand new institute at the University Health Network. He now has a lot of money to help move some of these products forward. We were fortunate enough to win one of the team grants to look at cannabis-based medicine for osteoarthritis. Dr. Kochra is a medical chemist, and Dr. LaRue is the Toronto Western surgeon associated with our ongoing research efforts at UHN. I'm going to wrap up by describing this project to you, and this is the project that we launched in July. We're well on our way to enrolling our 2,000 patients, but I thought it's important to understand because any Canadian physician across the country can actually participate and enroll a patient in this project. And here's why. People are asking, what's the rationale to do this? And first of all, so everybody knows, there's absolutely no kickback for you. There will be no money for putting your patients into this study. It is simply a snapshot of 6 months of a 6-month journey for your patients. Upon enrollment, we will be looking at patients that have either a chronic pain, a sleep, or an anxiety issue. You can see the validated questionnaires that will be administered at baseline, 6 weeks, 12 weeks, and 6 months. And we will track these patients out of our hub here at UHN. each physician that wants to use or have a patient be enrolled will have a e-prescriber login, which allows you to then focus in on what your patients are consuming and how you go about tracking them over the next 6 months. It's all an online consent process for your patient. If you're interested, I'm more than happy to tell you more. Each of these products, what's the difference here? The difference here is that each of these products will have a true trace technology backed product, and I'll explain what that means. And each of them has had an NMR mass spec for every ingredient that is in one of these products. And so for those of you who are fantasy football buffs or fantasy sports buffs out there, these are the folks that have built the back-end technology to track up-to-date live stats, that have created the backbone of tracking all of these products across the country. But here is the money for your patient. Each product has been tested by a third-party lab. There are 3 labs in particular that have signed on to this project. Sigma Lab, and Avandia, and a High North Lab. Any one of these will then give you your certificate of analysis to ensure that what your patient gets is actually what's on the bottle. And I think those of you that have been following this space have seen the number of class action lawsuits in the US. There was just the first one in Canada a few months ago. And just having an understanding that, you know, what your patient is getting is what is in the bottle is a novel concept 7 years into this industry. And so I do want you to understand that that is the reason you'd want, if I were a physician who had never actually danced in this space, to go about and do that. This is the website if you'd like more information, mcrwe.ca. We have a link for both patients and healthcare practitioners. And what you will see is, again, all of the documents associated with this are informed consent, as well as the REB approval documents are for view for each and every one of you. So I hope in that 20 minutes you've been somewhat entertained with our perioperative guidelines. It should be, I'm at the end of today going to be sending back the proofs, and should be available online hopefully by mid-November. Thanks very much, Rob, and the committee, and I'll hand it over. I'd much rather be in Lake Louise hanging out with you guys today, but this will have to do.